everyone. Welcome back to our monthly webinar series, Conversations on Character and the Common Good. This series is part of Virtues and Vocations, a national forum housed at the Institute for Social Concerns at the University of Notre Dame and supported by the Kern Family Foundation. I'm Suzanne Shanahan, and I direct the Institute for Social Concerns, and I'm host of this series. Virtues and Vocations seeks to foster a community of practice among scholars and practitioners across disciplines who are keen to understand how best to cultivate character and moral purpose in higher education and the professions. This webinar series is one of the ways we facilitate these conversations. Another is through a biannual magazine called Virtues and Vocations, Higher Education for Human Flourishing. This month, we are thrilled to bring these two parts of our initiative together through an extended conversation with two authors from our recently released issue on generosity. This issue included a series of deeply reflective essays from faculty and academic leaders from across the country. Today in particular, we welcome two of these authors, both physicians, Dr. Sneha Mantri and Dr. Abraham Nussbaum. They are super smart, fun, and engaging folks, very thoughtful on this issue of generosity in medicine. Dr. Mantri is a physician and director of Medical Humanities at Duke University School of Medicine. She directs the medicine school's Armstrong Humanities Scholars Program and was selected as a Macy Faculty Scholar for the 2024 to 26 cohort to expand interprofessional programs in health humanities and ethics across Duke's health professional programs. She is also founding editor of the Intima, a journal of narrative medicine, and a former writer for Synapsis. She is currently working on a historical novel on the eugenics movement of the early 20th century. Abraham Nussbaum, MD, is a physician. He is also Chief Education Officer at Denver Health. As a teacher, he teaches the basic sciences underlying psychiatry for first-year medical students at the University of Colorado School of Medicine, where he is also a professor of psychiatry and an assistant dean of graduate medical education. He is the author of several books, including the recently released Progress Notes. Again, Mantri and Nussbaum each wrote beautiful essays on generosity for our fall issue, wherein they ignite our moral imagination, asking us to consider how we achieve health and create a flourishing healthcare system. Welcome to you both.
Thank you so much for having us.
Yeah, it's great to be here.
Okay, so one of the things I especially loved about each of your essays was that at the core of it, there was a story. Abraham, for you, it was the two Josh problem. And for you, Sneha, there was a parable. I wonder if we could start with you, Abraham, and you could just lay out that story or vignette that oriented your essay for us.
Yeah, thank you so much. I'm grateful to be here, grateful for all the work you're doing at the Institute now for social concerns. I also love Dr. Mantri's essay and lots of the essays in there. In the essay, I was trying to reflect on the ways that medical care is and is not like repair of bicycles. A lot of times people think about the repair of bicycles as a strictly mechanical process. And similarly, people can think of medical care as also a strictly mechanical process. I have a broken derailleur, it needs to be thrown away and replaced. I have a broken hip, it needs to be replaced. And I was reflecting on an experience I had with two Joshes in my life, one of whom's an intern in psychiatry, and another Josh is a young man who works at a bike shop that I like to frequent that's tucked upstairs in a hardware store near my house. And the first Josh I met during orientation, and oftentimes during intern orientation, I try to engage the residents and to think a little differently and to get engaged in their community. I'm a big believer that a big part of their success is about trying to find some life outside the hospital that roots them. And this Josh, we wound up talking about bicycles. And he said, I really have a bicycle. I want it fixed. I want to ride. He was from Florida. And I recommended that he go see the other Josh at the bike shop. And I ran into him 8 months later and I'd asked him if he'd been biking to work. And he said, no, because his bike wasn't repaired. And I said, had you visited the other Josh? And he said, no, I've been too busy. And that experience of busyness is common to lots of Americans, but acute for medical residents. People who are in their intern year have a sense that their life is incredibly time scarce and that they don't have time for any of the things. The theme of the issue is generosity, but even to have their bike fixed. And in the story, I talked about my encounter of working at the bike shop and having to meet the other Josh when he finally showed up at the bike shop. And I talk a little bit about the differences between encountering him in the hospital or encountering him in the bike shop.
Great. Sneha, there's also a parable at the base of yours. I wonder if you could speak to that.
Yeah, I think, the parable that I use to sort of illustrate the challenge sometimes of generosity and how we conceive of generosity in medicine comes from the Mahabharata, which is sort of the central epic of ancient India and Hinduism in particular. And in this story, you've got two warriors, one Arjun, who's a warrior prince, on one side of the great war and in the Mahabharata, and on the other side, Karna, who's a adopted. He was adopted as an infant by a charioteer and sort of has become a warrior on the other side of the war. And the two of them are sort of arguing, if you will, about who is the more generous person. Generosity being a central virtue in Hinduism, as it is in so many other spiritual and religious traditions. And the sort of the god Krishna creates this mound of gold and asks them to distribute the gold among a village to illustrate, generosity. And Arjun starts by sort of handing out gold to each of the villagers who form, a line, and each of them receives their gold. And by the end of the day, the mountain of gold is, somewhat diminished. But the next morning when he wakes up, because it's a magical mountain, again, there's more gold again, and he has to distribute it again, and it's this impossible task. Whereas Karna takes a very different approach. Instead of being the one to hand out the gold to each person, Karna instead says to the villagers, "This is yours, do what you like with it, distribute it how you see fit." So he's giving the agency over that mountain of gold to the people themselves. So a very, very different approach to generosity. And what can an individual person do versus a collective in the face of, in this case, great wealth, but you could also apply it to medicine in that, we've always got more patients who need to be seen, who want to be seen. And how can we rethink the way that we care for our patients and our clinicians in order to sort of make sure that everybody gets what they need and is distributed appropriately across society.
Great. So what I love about each of these is how they are trying to address implicit challenges that you've identified within the profession of healthcare. And as I reread the essays, I was reflecting on a piece that was in the Washington Post yesterday. I don't know if either of you saw it, but it was talking about the challenges of work-life balance amongst physicians, right? Which is something certainly that has been a great deal in the news, both before, but perhaps even exacerbated by COVID. And it was reflecting on sort of a generational divide and the way that physicians understand their work. And I think very much, Abraham, the sort of more traditional route is this is all encompassing. This is all you do. That being a physician is who you are and how you spend all your time. So it makes perfect sense that Josh doesn't have time to fix his bike because he shouldn't have time to ride a bike because all he should care about is being a doctor. And the kind of piece goes on to reflect on a more recent generation that is pushing for more clearly defined hours so they can spend time with family and pursue things outside of the medical profession. And I just wonder if from your perspectives, you're seeing this kind of generational divide. Are there different ways to think about medicine as young people are coming in? And is that reflective of broader culture or deliberative approaches within medical education itself? Maybe
Yeah.
Abraham.
Yeah, thanks. Dr. Mantri raised all these questions, right? She talked about this question of an argument about who's more generous and what does generosity mean? She talked about individual responses versus collective responses. And she talked about agency. And I think these are the kinds of things that are going on in debates in medicine. I had the chance to write an op-ed for the Boston Globe where I compared The Bear to what's going on in medicine. And then if you watch the television show The Bear, you see these generational conflicts about what it means to be excellent in your work and then how much of your life you should give to work, right? And I think about the ways that if you think about cooking a meal or caring for a person, most of that is done in non-professional settings. It's done in the home, in the community, frankly, largely by women. And what we think about either cooking a meal or caring for the body, those are professional versions of things that we all do in any functional community. And I think the real challenge is the question that we have monetized care. We've said how much it costs. And in many ways, we've devalued all kinds of service work. So Brad, the mechanic that I talk about in my piece, or Josh, his apprentice, they get paid very poorly in comparison to a physician. We've elevated certain kinds of technical care and pay it quite well. But now we have this conflict about what do we do as the value of that continues to erode, right? And we see that in lots of helping professions, childcare professionals, dependent care professionals, right? In my world, behavioral health techs, nursing homes. And then meanwhile, we have young people who say, this is a well-paid life, but also an intense and emotionally demanding one. I want to figure out how to do it and live my life at the same time. So absolutely, we're seeing these questions throughout the hospital, and it's really creating a generational divide in medicine. For people interested, I recommend Lisa Rosenbaum from the New England Journal of Medicine. She has a terrific podcast series called NOS, where she's really talking to people about those things. And so absolutely every day we're seeing this going on. And I think the questions that Dr. Mantri raised are, how do we give agency to physicians? How do we build collective will? And how do we decide what it really means to be generous in medicine?
I mean, I do think that it's a generational divide, and it's certainly something that we're seeing much more explicitly now as something that, you know, young physicians, trainees, early career, both value and explicitly say they value in interviews and in online spaces. So I think there, you know, generationally, I do see a shift. I also think it's reflective of a larger cultural shift. You know, as you allude to, Abraham, around like, what does it mean? How do we as a society value different types of work differently? You know, I frankly think that the work that home healthcare workers are doing to care for my patients with Parkinson's disease is far and away more valuable than the work that I do titrating their Cinemet dosing. And yet those two things are, you know, valued by society at very different rates. They have very different entry points. And, you know, I think that it gets really hard when you start, as you have to do in a society, you have to make work transactional in some capacity. Otherwise, you'll never get people to do the hard work. But it also, I think, limits our ability to be generous in the same way that we are when things are non-transactional or non-economically or financially based. So I think it's a really tough sort of line to walk. You know, on the one hand, as a physician, and especially I think when you're in medical school or training, that may be the only time you get to experience something, especially in a supervised way where you've got hopefully other people around in the hospital or in the clinic that sort of have your back, if you will, and can teach you how to do things. Like, that's a very specific time in your training. But that's also used, I think, to historically abuse people and work them way past sort of safe limits. on care. And so I think, this conversation about work-life balance is certainly much broader than medicine. The stakes may be a little bit different for medical professionals than they are for other types of work. But increasingly what I'm seeing and what resonates with me, at least at this stage of my career and my life, is really the term work-life integration, and trying to find ways that, your work and everything else that you care about can, to some degree, try and sync up. So it doesn't feel like you're sacrificing one for the other, but they're kind of working in synergy. And that's not always possible, but when it does happen, it's a beautiful, beautiful thing.
So I just want to pick up on a couple of points that I think you've implicitly raised. And the first one is a bit about the privilege of the medical profession in having this conversation about work-life balance. So in this, and I don't know if it was, how well researched, but it said that on average, physicians work 59 hours a week. And using your example of home healthcare workers for Parkinson's, my father has been bedridden with Parkinson's for 19 months now, and has a home healthcare worker who works well beyond 60 hours each week, and is not in a position to be thinking about work-life balance, given the amount that she gets paid by the VA. And it's also it's the nature of care, right? So are we paying people less and caring less about their overall work-life balance, their well-being in professions that are really proximate to people, right? So the person who is there with him daily, monitoring every different iteration of his well-being. And then, it's rare that he actually sees a physician at this point. He's sort of beyond that kind of health and assistance. And yet that's the person that we're not really worried about. So is there a degree of privilege in this space? Is the first piece of it. But then also the fact that was raised about proximity to the individuals and our care for them. Again, this article states that physicians are spending 13% of their total time with patients, which seems to be a really small percentage, right? And right, so I'm trying to figure out how these things kind of go together. Are we valuing certain kinds of work and then privileging that such that those individuals, we can care about their work-life balance in a slightly different way or not? Would that be a fair statement, unfair?
I think it's certainly true that we in a society sense, not like myself and Dr. Nussbaum personally, but that we as a society really devalue proximate care and like the actual hands-on work that goes into caring for another person, whether it's at the beginning of their life or the end of their life or anywhere in between. I certainly recall, like, when I was in my own training, like as an intern, I felt like I spent, a couple of minutes with each of my patients in the morning when rounding, and the rest of the day was spent in front of a computer, right? Putting in orders, responding to pages. We did table rounds rather than bedside rounds because that was more efficient. So that gets to the other thing that we as a profession at least value efficiency. And I don't mean to, knock efficiency. I think that is an important skill to learn and to be adept at. But I think we're focusing so much on the efficiency and the technical prowess, and sort of the jockeying of the electronic medical record, that we're losing sight of the physical exam, of the connecting with another human being and another human being's story, that I think home healthcare workers or nurses or techs often end up doing a lot of that work in the hospital in an unrecognized way. One of my colleagues here at Duke, Neil Prose, did a documentary several years ago called Keepers of the House about the relationship that housekeeping staff form with patients, especially patients who are hospitalized for a prolonged period of time, and how that connection is so often unrecognized by anybody else on the healthcare team. It's an incredibly moving documentary, and I encourage everyone to watch it. But I think it really speaks to that sort of imbalance between who's thinking about the work and who's actually doing the work sometimes.
Yeah, I recommend the documentary as well. Suzanne, the answer to your question is absolutely. There's a ton of privilege in physicians being able to ask that question. Look, I love being a physician, but Brookings Institute says going to med school is the most reliable way to join the 1% in American economic life, right? That's frightening. And for my book, one of the things I had an occasion to do was to look at different salaries over time. And I found these data tables that showed what a teacher in Baltimore Public School District was making in the 1950s and what Johns Hopkins radiologists were making. And it was basically the same. And those are two really critical social roles. And when a public school teacher and a radiologist are getting paid the same, people are choosing them for the intrinsic good of those professions. And now it's a very different scenario. When we ask young people in our med school and other med schools, hey, do you look and take a peek at how much salary you're going to make and when you're picking these fields? They say yes. And they see clearly that the further away they get from the bedside, the more they make. Even if they pick a job, right? If you take a job in medicine and you become a physician, the physician who manages the team or the physician who manages that team gets paid more than the folks who are at the bedside. And we're telling people quite explicitly, the care that we value is the care that moves away from the bedside. So what generosity in medicine often means is recognizing those things that aren't valued, right? And engaging in those kinds of human behaviors that aren't valued. And that's part of what I loved about Dr. Mantri's question here is this debate about who's the most generous that she sees in the parable, right? And I think you can make an argument, as in her example, that the housekeepers often have more generosity than the physicians. One possible future for medicine is that it becomes a highly skilled technical set of skills that are well reimbursed, and that we don't think of it as a caring profession. We think of it as a technical profession. That's one possibility.
And so, as you think about that as a possibility, I'm both struck by the extent to which it seems, right, oftentimes as a technical profession, as a person who experiences, goes to the doctor, and it does feel largely technical, and the caring part often seems haphazard if it exists at all. But clearly there's an opportunity lost. And as physicians, maybe you can talk a little bit about that loss. And then after that, I just want to return to this notion of integrating life and work a little bit, because I think this is a hugely important point that brings us back to the two Josh problem as well. But if you could speak to that, wouldn't you lament that?
Very much. I mean, from my perspective, right? And I'm speaking from the perspective of a person who is a writer as much as a physician and an educator as much as a clinician. And so I'm always kind of thinking in both modes. But I think what draws so many people into healthcare professions, physicians, nurses, therapists, is a desire to look at human suffering and do something about it. And whether that's doing something by, a surgery or some other technical procedural skill, or doing something by simply standing with somebody as they, navigate a devastating diagnosis or end of life planning, or reworking or reshaping what they imagined their life to be. I think both of those need to be valued in the same way, even though they're very different skill sets. We sometimes talk about like the hard skills in medicine, like the technical stuff, and the quote soft skills, which is the stuff that I teach in humanities and ethics. But frankly, I mean, the humanities and ethics, like doing that well is, I think, much harder than learning to suture or learning to, administer various kinds of injections or the other sort of technical things that we also need to learn as physicians. It's much, much harder to tell a 40-something mother of 3 that she has a devastating and incurable diagnosis than it is to, inject Botox, for instance, or to program her deep brain stimulator, and all of this other stuff. And so I think we really need to kind of reframe how we teach our learners and the types of things we, as Dr. Nussbaum was saying, the types of hidden curriculum things that they're picking up on the wards as they see, who's valued in healthcare. And it's often not the palliative care physicians or the social workers or the case managers who are doing a lot of that really deep work with patients, but are not sort of recognized in the same way at a administrative level.
You've got this great quote I just want to share with folks in the essay on page 107. It says, academic medicine needs to become generous with our time and resources if we are truly to make a difference for the community we profess to serve. And I think that really echoes what you're trying to say. Abraham, did you have any thoughts here?
Yeah, no, I totally agree. I think that from my perspective, one of the things that's happened as we've changed our training environments is that we've taken out some of the generosity and focused just on the stuff that's deliverable. And you'll see that when I was a trainee, we were just the first kind of years to do duty hours. And so the faculty didn't really believe in duty hours. So we basically just worked all the time. But the flip side is that it was very social. There were lots of people in the hospital together. And so we would do things at night together. And there was a sense of camaraderie. One of the challenges for our trainees today is that they come in for shift work, right? And so when they talk about work-life balance, it's often because they've trained very differently. They've experienced this as something where they come in for 12 hours, and during those 12 hours, they're working very hard. And we've taken out a lot of the time for small interactions, right? There's a book that I love by Victoria Sweet, God's Hotel, where she talks about all of these nurses who, when there weren't a lot of patients, they would knit blankets for them, right? And then a hospital efficiency manager takes over and says, hey, if there aren't a lot of patients to do, we're going to send the nurses home and we're not going to pay them for that time. And that's become common in nursing staff. We downstaff them when there's not enough patients for them. But meanwhile, there's no one making the blankets. And so the question is then, how do you come up with a social structure that reinfuses generosity back into medicine? Because it should be there, right? The act of caring for a sick person, and why people went into this is because they wanted to be generous and receive generosity. One way is to stop selecting young people straight out of undergrad and to stop saying that the best training for this work is to say that you've made a blitzkrieg through the basic sciences, right? There's evidence dating back decades that people who take just 2 or 3 years between med school and undergrad, people who study the medical humanities are better off doing it. On the flip side, if you go to a medical humanities conference and you listen to a lot of physician narratives, they often have a similar arc. And a friend of mine she said, why is it that you all spend so much time with disease, and then the first time you figure out what disease really is when you get sick yourself? She says, so many of the physician memoirs are about, oh, I didn't realize that disease could happen to me too. And so one way to change medicine would just be to take some people with a little life experience, people who've cared for a sick person, who've been sick themselves, who've worked out a little bit, who have children, right? That alone, I think, would shift some of the conversations in medicine.
Right. I think the other piece, in addition to having folks who have some experience, is alluding a little bit to this work-life balance. You talked about the kind of duty hours and how you would then socialize. I think is this perhaps what you were talking a little bit about in terms of work-life integration, how this can be more of a community that does more than just clocking in and clocking out. And how would you suggest this notion of integration? Because I think partly this is the Josh story. How does riding your bike become a way that you're actually a better physician?
Yeah, great. I'd love to answer that question. I feel a little guilty that there's my bike hook today, and I didn't ride the bike. There was a first snowstorm of the year, and I wasn't quite prepared. So usually I would have my bike here too. Riding a bike is a great way to get to know your community and to see it around, right? There's all kinds of evidence actually in the flourishing literature that people who bike commute are some of the people who are most connected to what their community's doing. But broadly speaking, right, we started biking to work at one point during residency because we had only one car and we had an infant. My wife and I were both resident physicians, and that's how it started. And you found that you just were in the world in a different way. And I would say that biking to work usually is some of the best times I have because I get a small little dose of exercise, but I see and interact with people. I can't tell you how many times I'm biking home from work and I wind up talking to somebody. And so I wound up inviting bike Josh on a century ride, right? I did the 50-mile version because I'm old, and he did the 100-mile version. And it was an awesome kind of encounter to engage him in a different way than I normally would as an attending physician. Because an attending physician, I'm asking, are you going to be at lecture? Did you do the reading? Have you seen the patients? Have you written the notes? And instead, I engaged him in this different way of, hey, you want to go on a long bike ride? And I think that's the question about how we engage people differently. It shifts the encounter and the register.
Right. Sneha, do you have any thoughts on this?
Yeah, I mean, I think that's absolutely true. I am not a biker, at least not at this stage in my life, but I do take the bus to work, and I experience a lot of that same, right? Like I feel like I'm actually part of a community outside of the hospital setting when I'm walking to the bus stop, when I'm on the bus. And because, I'm usually taking the bus at about the same time every day, you're with other people who are also taking the bus at the same time every day. And you start to see familiar faces, and you start to feel like you're a part of something beyond your, the hospital or the clinic or, whoever it is that's signing your paycheck. It's a different relationship with the world around you. I think that you don't get when, we're all enclosed in 2-ton pounds of steel. That's a whole nother conversation about urban planning. But I think that, the moments when I have felt the greatest flow, if you will, there's this concept of a flow state where your work and your life and all the pieces of yourself are kind of coming together, have really, for me, been about health humanities and the ability to bring storytelling into clinic, to bring the clinical lens into a story. Like those moments of integration for me are just so beautiful and so life affirming and profession affirming. I wonder sometimes if part of this conversation that we're hearing around the need for work-life balance, I'll use that term, is really about people trying to figure out a way that they can make this profession and this career choice sustainable, because there is so much emotional loss and emotional intensity in healthcare. And if you don't step back from that and sort of take a different lens, you risk kind of turning into an automaton in some ways. The person who comes in, puts in the orders, does sign out and goes home. But I think, really thinking hard about what it means to be part of a community when you're doing that is perhaps more fundamental than the actual hours worked versus hours at home.
Yes, Suzanne, if I might comment on that, Dr. Mantri's comment. So I had this really interesting encounter with a psychiatry resident last week. Great, very thoughtful young man. He'd completed an MD, PhD, extraordinarily educated, right? And he in earnest said to me, he said, I feel like my brain is broken by intern year. And he says, I really feel like after a day in the MICU, I really need to have like 2 days off. And I, on the one hand, sympathized with them because I remember doing MICU rotations. Psychiatrists aren't really meant to run in MICUs. And I also registered your concern about the kind of privilege that that comment includes. But mostly what I wanted to do was have a further conversation with him and to think about that question. And is the right answer that you should have more time off? Or is the answer that you need to figure out how to find meaning in that work? And so my goal for him would be for him to say, why do we want you to do 2 months in the MICU, even though that's not your future? How can you do that work so that you experience that as a chance to receive generosity from other people and to be a generous person? And that's where I do think some things like the medical humanities, but also this conversation about how to find meaning in medicine is the secret to this question of moving from work-life balance, where you often talk about defending yourself from the changes that medical training does to you, and moving towards work-life integration, where you say, look, I'm going to be a different person after medical training, and I've got to figure out how for that person to be a good version of myself, right? So I agree with you. I think it needs to move towards integration.
That's great. I'm wondering, Abraham, you mentioned the importance of perhaps students taking more time off, having greater life experience before they jump into medical school. I wonder what's the mix of the kind of young person that we're encouraging to go to medical school, the kind of background they have. You both have strong humanistic training prior to going to medical school. And that's been a thread that's maintained. So what's the kind of admission selection criterion? And then what's the kind of things, what are the kinds of things we might be doing differently in our medical training and our training of residents to enable them to have this work-life integration, to enable them to be generous, receive and give generosity?
I laugh because Suzanne, you know my son, of course.
I do.
And he is the child of two physicians, and he goes to Notre Dame. And at the end of his freshman year, he goes to the Notre Dame pre-med advisor and is like, hey, I think I might want to be a pre-med. And the Notre Dame advisor tells him it's too late. And I thought, and we said to him, not at all, right? You're 19 years old. Not too late. It's too late to become an NBA superstar, right? That's not going to happen for you. This is your father. That's not going to happen for you. But it blew my mind that somebody would say that to him, right? And so we said to him, hey, probably what that means is that you may not be able to go straight through without a lot of work. That's not a problem. There's all kinds of evidence that people who do best in med school are the people who have studied the liberal arts and have some liberal arts degree. There's a certain level of work ethic and of intellectual ability you need to do to get through med school. But the number of people who have that is actually quite large, right? So many med schools get over 10,000 applications for like 150 slots, right? And if you talk to a dean of admissions, they'll tell you most of those kids can do the work. As a society, we've over-selected kids from particular backgrounds, men, white people, Protestants, able-bodied, etc., right? And we have this huge problem because then we have, Dr. Mantri talks about the ways that many times patients identify more with the EBS workers because they recognize them as having some representation in their community. There's lots of communities that are underrepresented in medicine as a result of saying, the way forward here is to go to an elite university, race through it, get great grades, great test scores, and then show up for med school. Those are all good things. Respect to all the kids who can pull that off. But there's also kids who say, I'm going to study poetry or history and also take some physics classes and spend a year as a home health aide. And then maybe 2 years as home health aide, volunteer for AmeriCorps or Teach for America. That's a great set of backgrounds, right? And I would say that on the back end, when I talk to program directors, a lot of them say that secretly they want kids who have some real life experience outside of med school. Kids who've worked on a farm, kids who've been in the military, kids who've cared for a family member who's sick, kids who've had another career, and they actually know what it is to have a job. And I think they often respond differently to medical training than the folks who went straight through a meritocratic in university system. So.
Yeah, I agree. I mean, I think the traditional model of medical training, right, is this very clear sort of like a step ladder. Like you do this, and then you do this, and then you do this, and ultimately you get to the top of the ladder, which is you are an attending. And then the interesting thing is that when you do get to the top of that ladder, right, then you look back at all of this stuff that you did, all of these hoops that you had to jump through, if I can mix my metaphors here, all of these things that you had to do to get there. And to some degree, it's like, well, why? Like, what is it about all of these experiences that I've accumulated? How did they shape me as a physician? Like, I was one of those people who sort of went straight through college to med school to residency fellowship and now here. And, my one, I guess, moment of resistance was that I majored in comparative literature. And I also obviously took all the, biochem and physics and all of the pre-med requirements. And I feel like I strongly feel that I use that literature part of me and that literature side of my brain every single day, particularly when I'm in clinic, even more than on my non-clinic academic days, where you would think, oh yeah, the literature stuff fits with health humanities, but it's in the clinical space, the ability to listen to story and to understand how patients are experiencing their illness. That I'm really drawing on the literary theory background. And so I agree. I mean, I think we need to really rethink the ways that we get people on this kind of climbing this ladder mentality, and instead encourage students in high school, in college, to use that as a time of exploration. And what can you do to form yourself as a person, because I don't think you can be a good doctor or a good nurse or a good therapist unless you're sort of a good person first. And then you can get into, this whole debate about, well, what is a good person and how do you form a good person, which is kind of the Institute's mission in a lot of ways. But I think, our traditional model really isn't meeting the needs of patients, and particularly patients from underserved communities. Like, I think that's very clear. So, do we have an opportunity now to rethink how we select students into med school, how we select those medical students into different residency programs? Sometimes I feel like the whole system is kind of geared towards a particular outcome, and we're realizing that outcome is not helpful for patients. It's not helpful for the physicians. It's not helpful for anybody, it seems.
That's great. I wonder if there are particular things that you think whoever ends up in medical school, particular programs or interventions or approaches that you think we should be trying, working with. I know you both play really pivotal roles in the education in both of your institutions. Are there exemplar programs or crazy wild ideas that if you were in charge of the world, you would do? Yeah, whatever you want to jump in with.
Yeah, absolutely, right? Dr. Mantri talked about the ways in which this system is overdetermined to produce certain people. If you recruit kids who've made it through elite cultural spaces, they then want to practice in elite cultural spaces. And that's actually not where we need doctors. So one is changing who you select on the back end. But then it's also about how you train them. I'll call out two examples. One, so my last book's about the longitudinal integrated clerkship model, where students follow patients instead of physicians. They work in small cohorts. They do team-based training. It's a relational model. I'm a psychiatrist. We like relational things. That's, I think, the medical education model for undergrad medical education that has the best evidence. The second thing I'd call out is when you think about physician training, part of what makes it different than other kinds of training is that it's subsidized by all of us. So people don't typically know this, but every 2 weeks when your paycheck comes and a portion of it goes to Medicare, over billions of dollars of that go annually to cover physician medical education for residents. And people don't realize the ways that actually then distributes doctors in odd ways. One of the best ways forward is what's called the Teaching Health Center funding, which says, hey, look, we need to make sure that physicians are being trained in the places where we need doctors, rural and urban underserved areas. The docs who come out of that are more diverse, they're more committed to underserved care, they're more reflective. So there are these structural decisions that we can make, changing our educational models like the LIC, changing the way that we choose to spend our tax dollars, like the teaching health centers, that I think can make a big difference.
Great.
Yeah, I agree. We need to sort of revamp at all levels, including, how are we selecting students into medical school in the first place? As Abraham mentioned, there are many, many more students who can do the work, who have the work ethic and the drive and the knowledge to succeed than there are places in med school. I've recently, this past year, actually, I've started doing our what is it called? Multiple mini interviews, MMI, which is a different style of selection and sort of admissions committee work than the traditional interview model, where you have an opportunity to sit down with a faculty member for half an hour and talk about yourself and what drew you into medicine. And instead, the MMI model, which I believe was piloted at McMaster in Canada and is now kind of spreading nationally or internationally, I guess, is really about focusing on very short sort of ethical dilemmas or challenging topics or controversial topics in healthcare. And it's been really eye-opening to me to see how these young people, mostly in their final year of college or, shortly out of college, are talking through and thinking about these really big picture issues and able to articulate, different perspectives and different styles of knowledge. And so I do think that that kind of model will select a very different kind of person than your traditional, what was your GPA, what was your MCAT score, are you able to, talk intelligently about yourself for half an hour to a faculty member model. I'm very curious to see kind of how this reshapes medical school, residency training and beyond. I will say that one model that I was very excited about that I don't know has panned out in quite the way people thought it would was the model of tuition-free medical school, which was sort of intended to be a way to get people more engaged in primary care specialties or primary care areas because they wouldn't have the sort of crushing educational debt of med school. But I think what we've seen, at least over the last couple of years, as those cohorts of students have now graduated and placed into residency, is that it really hasn't shifted the number of students going into primary care. So I think that speaks more to a bigger cultural shift needed in the way that primary care is valued and reimbursed and the way that rural health is valued and reimbursed. That's sort of a bigger topic than medical school itself, but certainly has an impact on, this growing shortage of primary care physicians, particularly in underserved areas.
Yeah. And Suzanne, you talked about privilege. One of the ways that medicine is so privileged is that unlike any other profession, our training is subsidized by everyone, right? And that's a really open question that we ought to be having is why do we subsidize ours and not childcare workers or home health workers? And then within medicine, the way that works is that a hospital is awarded a certain amount of FTE that they can choose how they spend. But there's lots of kind of doctors that probably a market-based solution is going to create. And then there's other kinds of doctors, primarily primary care doctors and pediatricians, geriatricians, who it wouldn't create. And one discussion that I've tried to be a part of is this question about why don't we just say, hey, look, if we're going to subsidize medical education, let's at least subsidize the kinds of people that a market solution won't produce on its own, right? God bless neurosurgeons, but people will find their way to neurosurgery without subsidies from everybody's paycheck.
That's great. So I have to say, this is kind of revelatory news for me. Had no idea that was actually a mechanism. So perhaps there are others you're enlightening in this conversation. So, yeah.
I'm a part of a group called GME Transformation, and anytime anybody wants to talk, I can bend your ear about exactly how much money goes to this. Anyway.
That's wild. There are questions feverishly teeing up, so I want to get to some of them. So let's see here with the first one. What role can I play as a first-year medical student to promote or engage with the need for generosity in medicine, even as I already feel the pull towards needing to focus on the topics I am being tested on? How can I keep myself committed to learning and improving on soft skills and helping to engage my peers in this as well? Who's got some advice?
Yeah, I mean, I can step in and at least share, the things that work for me as a medical student and the things that I'm trying to inculcate in our med students here. I mean, I chose the medical school that I went to specifically because they had opportunities, developing opportunities at that time that have now grown even farther in health humanities and literature and medicine and narrative medicine. And I would build time into my schedule to do that kind of work. Like as an example, I remember as a first year med student, I think our lectures did not start until 10 in the morning. I would wake up at 8 and write for 2 hours before going to class. And that was sort of the thing that I did and the thing that kept me connected to that part of myself, through my preclinical training. I think if you're at a school that doesn't already have that built in, there are opportunities to work with, your student council or student clubs to grow and develop, a literary society, a literary journal, narrative medicine training, because if you're thinking about it as a first year med student, there are going to be other students in your class and throughout your school that are thinking about it. And there are going to be faculty members that are thinking about it. And so I think a big thing, a really important thing here is the value of community in sustaining humanities practice. This is not something that any of us can do alone, and having others kind of walking alongside you with it is really huge.
Great. Abraham, did you want to jump in, or you?
Yeah, so I wrote a piece a couple years ago called The Reading Cure for Pharaohs, which is a medical magazine. And I agree with you. Have a reading practice that is outside of medicine. 2 is volunteer at a free clinic so you can see some of the health inequities and start getting reminding of what you do. 3 is to join a community outside of med school, right? Whether that's a church, a temple, something, probably not politics. It's not good for your mental health, right? Some sort of community, whether that's a group of writers or something else. And then the other thing is to make friends. I think a lot of times people receive the implicit message that the only thing that matters is their signal, how I do on my grades and my score. But the noise is often what sustains us. Make friends along the way. It's why I recommend going to class if you can, right? Going on a bike ride is a different kind of noise than just saying, I'm going to get to work the fastest way I can and air conditioned. You bike to school, you're going to be a little sweaty at the end, but you'll often experience the noise of the place. And it's the noise that I think sustains people. People will ask you about the signal, but the noise sustains.
Great. Sneha, this one is for you. And it's about, I had mentioned your novel on eugenics. And this person notes that it's a fascinating topic given biomedical engineering developments. Maybe you could tell us a little bit more about what you're doing there. It's very exciting.
Yeah, no, I'm happy to talk about the novel in progress, in revision. The novel itself is historical. It's focused on a case in the early 1920s of a young woman who named Carrie Buck, who was sterilized without her consent, and the case went to the Supreme Court and was the origin, if you will, of well, it formalized a lot of eugenics and forced sterilization in this country for the next 50 years until sort of the mid 70s when things started to turn around. But specifically, the Supreme Court case was the origin of the quote, 3 generations of imbeciles are enough, which is a really horrifying thing to contemplate. That somebody could say that. And as a neurologist myself, neurologists and psychiatrists were very heavily involved in those early eugenics cases, deciding who would or would not be sterilized. I think the contemporary move in bioengineering is certainly, I think, relevant point. Everything historical also has a contemporary corollary, right? And so again, as a neurologist, especially as a movement neurologist who does work with deep brain stimulators and other ways of kind of reconfiguring neural networks, it absolutely has, resonance today. I think that would maybe be another novel, a second novel, a sci-fi novel. But if that's an area that interests you or interests anyone on this call, I think I would recommend Kazuo Ishiguro's novel Clara and the Sun, which was published several years ago now, but sort of looks at AI and androids and robotic companions and what does it mean to be human and how does technology affect that.
Abraham?
Yeah, I guess I'll just say what it means to be human is to be a person like Dr. Mantri, right? Who can recommend a great novel, talk about our patients, think about history in the past, relate to them all. I'll give one last piece of advice. I read an essay a couple of years ago by a philosopher who did a book on midlife, and he talked about this problem of telic versus atelic goals. Medical training is a trap for people who are good at achieving goals. There's a ton of them. There's always some other goal in medicine. But the challenge is once you become a caregiver, you're spit on the other side, you have to live the atelic life, where you're just going to see 1,000 patients with schizophrenia or with movement disorders or take out gallbladders the rest of your life. And the question is, how do you prepare yourself for the atelic life? Medical training, you can't do it just by chasing after the telic goals of medical training. You got to get up at 2, before class and start working on your novel or reading something. So I mean it. I think the question is, you want to do the medical humanities like Dr. Mantri is describing. So.
Well, thank you both. We had a whole bunch of other questions I don't think we're going to get to. So I just want to see if either of you have any final thoughts on medicine and generosity before we say goodbye.
My last thought is that sometimes the most generous things I've seen in medicine are when patients engaged in acts of generosity. One of my favorites is we had a legally blind occupational therapist, and she talked about a patient who started to pull out the chair for her. And she said, that's when I knew they were well, is when that they could start engaging in acts of generosity again. So be mindful of those acts of generosity that patients can take on too.
That's beautiful. I think that's absolutely true. And it really speaks to the connection that generosity can bring in medicine, the generosity of our patients towards us as clinicians and the generosity that we hopefully bring into the clinical space ourselves. It's really fundamentally to me about two human beings sitting down and having a conversation about usually a very serious topic, but with intense knowledge of what's happening and intense attention to what's happening.
So I think there's all this concern in the ether about the medical profession, conversations about burnout, conversations about the instrumentalization of the profession. I have to say, talking to the two of you is such a hopeful thing that if all physicians could have this mindset, I think we'd be in an awfully good shape here. So way to be exemplars. So apologies to everybody who asked a fabulous question that we couldn't get to. But thank you all for joining us for this conversation, and join us on Monday, December 16th for a conversation with former Valencia president, Sandy Shugart, on character leadership and professional education. Thank you guys. This was really beautiful. Yeah.
Thank you so much.
This was wonderful. Thank you for having us.
Thank you.